Hello, my name is Sean Strickler, and I'm an instructor with Emory's Medical Imaging program. Today I'm going to be talking about MRI contrast, short and long-term adverse effects. The objectives for this lecture are to provide an overview of MRI contrast, discuss short-term and long-term adverse effects of gadolinium-based contrast agents, explain the current recommendations regarding gadolinium-based contrast agents, and describe some alternative imaging techniques that will reduce or eliminate the need for gadolinium-based contrast agents. Let's start with a history of MRI contrast usage. Following the FDA's approval in 1988, gadolinium-based contrast agents have been used for diagnosis and treatment guidance in more than 300 million patients worldwide. At Emory, we are performing greater than 50,000 MRI studies with contrast annually. 3/4 of those MRIs performed are with gadolinium-based contrast agents. Here is a breakdown of each procedure and the amount of studies that are performed with contrast. As you can see, breast MRI uses mostly contrast, as well as abdomen, head and neck, and chest. The spine and extremities don't use contrast as often. Gadolinium-based contrast agents are used every day to help radiologists accurately detect and diagnose a wide range of pathologies that might have gone undetected without contrast enhancement. MRI contrast is an essential part in the diagnosis of pathology. As you can see here, there's a 3 millimeter lesion that is brain metastatic cancer stage 4. That was not visualized on the pre-T1 weighted image on the left, but you can see it visualized here on the post-contrast T1 weighted image. MRI contrast is helpful for visualizing pathology in the brain, spine, musculoskeletal, the body, thorax, and with angiography. In the brain, contrast is used to examine neoplasm, infection, and demyelinating diseases. In the spine, it's used to evaluate post-operative surgical regions and to differentiate scar tissue from reherniating intervertebral disc material. In the thorax, contrast is used to perform stress perfusion and viability studies of the heart. For breast imaging, contrast is used to evaluate a nodule initially discovered on a mammogram, and it's going to be used to determine if that nodule is malignant or benign. With dynamic contrast enhancement, contrast is used to help detect and diagnose liver cancer by using time administration of contrast, where we're going to be watching the arterial, venous, and delayed phase as we watch that contrast go in and out of those particular organs. With musculoskeletal imaging, contrast is used to rule out injuries such as a rotator cuff or labral tear during arthrogram studies, where contrast is injected directly into the joint space. With MR angiography, or MRA, it is used to evaluate the morphology and hemodynamics of the vascular system. So how does MR contrast work? Contrast agents improve diagnostic value by shortening relaxation rates of surrounding tissues to broaden the contrast differences displayed on an image. The effects of contrast media influences the magnetization of tissues when it comes within the vicinity of an agent. This is important because it's different from our X-ray and CT contrast. gadolinium contrast media by itself is not what gives us contrast in our image. Once gadolinium contrast comes within 3 angstroms of a tissue, an interaction occurs and the relaxation is shortened. Contrast enhancement is due to the shortening of the T1 and T2 relaxation values. So you can see here we have a pathology in the right hemisphere of the brain, and the T1 weighted image, you can see those tissues have the same contrast, or almost the same contrast, as the brain tissue that it runs up against. And you can see that visualized by the relaxation curves of those tissues. But once we inject contrast, we're going to get shortening of those tissues that come within the vicinity of the gadolinium. It's going to shorten our T1 relaxation rates, and it will appear brighter or higher in signal on a T1 post-contrast weighted image. So it will increase our contrast enhancement, and it will increase the contrast between the 2 tissues. Further explanation of how MRI contrast works is it basically causes tissues to tumble at a frequency or precessional frequency closer to the Larmor frequency. Tissues that precess closer to the Larmor frequency will give off energy to the tissue lattice a lot faster, causing a faster T1 recovery rate, and those tissues will appear brighter on a T1 weighted image. As you can see here, once again, we have another example how we cannot see the meningioma on the T1 pre-contrast image. We inject contrast, and now we can see the enhancement of the meningioma, a benign cancer of the meninges, post-contrast. Gadolinium is the active element in most contrast media used in MRI. Gadolinium is part of the lanthanide rare earth metal family. It has an atomic number of 64. It has 7 unpaired electrons in the outermost shell. This is what makes it paramagnetic. The effects of paramagnetism on tissue is that it will shorten T1 and T2 relaxation and provide contrast on the image. So it will be brighter on a T1 weighted image, and it will appear darker on a T2 post-contrast image. So that's why we typically talk about, when we're discussing relaxation, we describe it in T1 relaxation because it's going to appear bright on our T1 post-contrast images. Unfortunately, gadolinium is a ferromagnetic free ion is highly toxic. Gadolinium is not a natural occurring substance and therefore can be harmful to our patients. It is considered a cumulative poison because the body is unable to excrete this heavy metal. This is similar to lead or mercury poisoning. So in order for gadolinium to be removed from the body, it must be bonded or chelated to a molecule that allows it to be filtered out of the patient. So to reduce toxicity, the gadolinium ion is bound or chelated to a ligand. Contrast agent now can be readily excreted by the body. A patient with normal kidney function will excrete the contrast usually within 24 hours. Gadolinium-based contrast agents differ by the ligand. Now let's describe some gadolinium-based contrast agent properties. We're going to review osmolality, viscosity, structure, stability, relaxivity, and dose. The first property we'll discuss is osmolality, and by definition, it is the concentration of a solution expressed as the total number of solute particles per liter. Viscosity describes the thickness of a contrast agent. If you increase viscosity of an agent, this is going to be associated with a higher number of non-allergic reactions. And I will describe what a non-allergic reaction is later in this lecture. Structure. Gadolinium-based contrast agents are classified by structure of the ligand. The ligand can be either macrocyclic or linear. With macrocyclic, the ligand forms a complete ring surrounding and encasing the gadolinium ion in a cage-like structure. This tends to hold on to the gadolinium more tightly. With a linear structure, you're going to have a more open structure forming an incomplete ring. This will be the reason that it is more prone to the release of gadolinium via transmetallation. So what is transmetallation? Transmetallation is when metal ions naturally occurring in the body, like iron, calcium, and zinc, begin to fight for the ligand that is attached to the gadolinium. If the gadolinium ion disassociates from the ligand, transmetallation has occurred. The longer the MR contrast media stays in the body, the more likely the ligand will disassociate. An example of when this could occur is when you have a patient with kidney dysfunction, where it's going to take longer for that gadolinium to be excreted from the body. As far as structure, these agents are also classified by whether they are ionic versus non-ionic. With ionic agents, a charge is used to strengthen a bond between two molecules because opposite charges attract. And you can see here with this chart that all of the non-ionic gadolinium-based contrast agents do not have the cation that is going to be attracted to the anion. The addition of an ionic charge enhances the stability of the complex. So here's just a chart that summarizes gadolinium-based contrast agent structure. As you can see here, in the column we have linear and macrocyclic, and in the top row it's classified by non-ionic and ionic. So our agents that are linear non-ionic are OmniScan and OptiMark. Our ionic linear agents are Magnavist, Multihance, Primovist, and Vasovist. Our macrocyclic non-ionic agents are Prohance and Gadovist. And our macrocyclic ionic agents, or agent, is Dotarim. The next property I'll discuss is stability, and more specifically, thermodynamic stability. Thermodynamic stability is based on the structure and bond between the ligand and the gadolinium metal ion. So when we're classifying these structures in terms of thermodynamic stability and which one has the highest thermodynamic stability, the macrocyclic ionic agents have the highest thermodynamic stability. The next highest is macrocyclic non-ionic, then comes the linear ionic, and the least stable in terms of thermodynamic stability is the linear non-ionic. Next, I'll discuss the kinetic stability. Kinetic stability reflects the speed at which the gadolinium ion is released and is evaluated using the dissociation half-life time of the gadolinium-based contrast agents under various conditions. In other words, how well the gadolinium-based contrast agent holds up in the chemical environment of the patient. Here's a chart summarizing the properties of the different gadolinium-based contrast agents on the market today. As you can see here, we have the brand name, we have the generic name, we have the chemical structure, we have the charge, their kinetic, thermodynamic stability, and their NSF risk. I want you to take note at the kinetic stability for our linear agents. As you can see, the dissociation half-life time is less than 5 seconds for our linear agents, but for our macrocyclic agents, we have, for Dotarim, it takes 338 hours to disassociate. For Prohance, it takes 3.9 hours, and for Gadavis, it takes 43 hours. In terms of thermodynamic stability, it is the macrocyclic ionic agent Dotarim that has the highest thermodynamic stability. The macrocyclic agents also have the lowest risk in terms of NSF, and I'll describe what NSF is later on in this lecture. The next property I'll discuss is relaxivity. Relaxivity describes how much T1 and T2 shortening will occur in tissues within the vicinity of gadolinium contrast. Basically describes how well a contrast media performs. The quicker the T1 relaxation rates, the higher signal intensity you will have on a T1 weighted image. So as you can see here, Multihance has the highest relaxivity, T1 relaxivity of the agents, meaning at a given dose it's going to appear the brightest or have the highest signal intensity on a T1 weighted image. That's probably where it was given the name. Dose. The standard dose for MR contrast is 0.1 millimoles per kilogram, but that can be confusing, so I did a simple conversion. Let's say we have a 170-pound patient. They will typically receive about 17 milliliters of contrast. That equates to 1 milliliter per 10 pounds. The lethal dose is 6 to 20 millimoles per kilogram. And as a reminder for our MR techs, after contrast is injected, we need to follow with a saline flush, at least 5 cc's. And a saline flush is required if you are injecting a very small amount of contrast. Here is a list of the FDA Approved Gadolinium-Based contrast agents. Most of these agents are extracellular. Eovist is a hepatobiliary agent. A hepatobiliary agent is excreted mostly by the liver and biliary ducts. And Ablavar is a blood pool agent. With blood pool agents, contrast will remain intravascular for a longer period of time, allowing arterial and venous circulation to be demonstrated because it has a higher molecular weight. So just take a look at all their different properties and their numbers associated with those properties. Emory did a SWOT analysis to decide which contrast agent is going to be their frontline agent. So in the past, Emory used Multihance because of its very high T1 relaxivity, but unfortunately it didn't have a very high molecular stability. And it's also been related to having higher brain deposition. So Emory has made the conscious effort to go with a more stable agent that has been associated with low NSF, low brain gadolinium deposition, lower allergic reactions, but unfortunately its T1 relaxivity is not as high. Our backup agent, if a patient has had a previous reaction to either CT or MR contrast, is Dotarim, because it has the lowest percentage of allergic reactions in terms of the gadolinium-based contrast agents. And it is a very highly stable complex, being that it is ionic and macrocyclic. Now let's talk about gadolinium-based contrast agent adverse effects. We'll start with the short-term effects. Short-term effects or short-term adverse effects occur within minutes, hours, or days after it was administered. And you have two types. You have allergic and non-allergic reactions. Allergic reactions are a type of reaction to a contrast media that causes the body to produce histamines. These can range from mild to severe, and the severe is often termed anaphylactic. With MR contrast, these occur in less than 1% of patients. Examples of allergic reactions are hives, sneezing, swelling, and with more serious reactions are cardiac and respiratory issues. Now let's discuss non-allergic reactions. Non-allergic reactions are also called chemotoxic reactions. A non-allergic reaction is a type of reaction that does not involve producing histamines in the body. This is a reaction to the act of injecting, not the autoimmune response. Examples include headache, nausea, emesis, dizziness, extravasation, and or even coolness at ejection site. This can be caused by higher viscosity agents. And I put down here as a reminder to our MR techs that any adverse reaction to a gadolinium-based contrast agent should be documented in the patient's medical record. Now let's talk about long-term adverse effects. A long-term adverse effect is one that usually occurs days, months, or years after the contrast was administered. And the examples are nephrogenic systemic fibrosis, NSF, gadolinium retention in tissues, gadolinium deposition in the brain, and anthropogenic. Let's talk about NSF first. In 2006, Grosvenor linked nephrogenic fibrosing dermopathy, which is now known as NSF, to gadolinium-based contrast agents. NSF develops exclusively in patients with renal insufficiency. Grosvenor also discovered that linear agents have been associated with the highest incidence of NSF reported cases. NSF is defined as a life-threatening condition characterized by fibrosis of the skin and connective tissues throughout the body. This can be a deadly disease. The etiology of this rare but serious disease is unknown, and no definitive treatment exists. Fortunately, by 2009, many reported NSF incidences were eliminated by avoiding or limiting the use of Group 1 agents in high-risk populations and by employing more stable non-Group 1 macrocyclic and linear protein gadolinium-based contrast agents. So you can see here the Group 1 agents that are associated with the greatest number of NSF cases, which are Omniscan, Magnavis, and Optimark. Group 2 agents are associated with few, if any, unconfounded cases of NSF, and those agents are Multihance, Gadavis, Dotarim, Prohance. And then Group 3, there's limited data regarding NSF risks, and one of the agents is Eofist, which once again is a hepatobiliary agent. So once we made that link between gadolinium-based contrast agents and being injected in patients with renal insufficiency and moving to more group 2 agents, we had basically eliminated incidences of NSF. Let's talk about our second long-term adverse effect of gadolinium, which is gadolinium retention in tissues. So animal studies have been performed using gadolinium-based contrast agents dating back all the way to 1992. These animal studies involved injecting rodents with gadolinium-based contrast agents and then analyzing the harvested tissues. Wiedeking, Kumar, and Tweedle in 1992 showed that administration of gadolinium-based contrast agents resulted in gadolinium deposits within the liver and femur of mice. These researchers followed up their study in 1995, and they studied the long-term distribution of gadolinium in mice and rats after the administration of 4 gadolinium-based contrast agents. Omniscan, which is a linear agent, documented as having the highest residual whole body gadolinium. Saber et al. In 2008 noted that gadolinium detected in animals injected with Omniscan, linear, was more than 30-fold higher compared to gadolinium concentrations detected following the administration of Gadolinium and Dotarim, which are both macrocyclic. Gadolinium retention in terms of human studies. Human studies involved analysis of tissue samples that were either surgically removed or biopsy. Gibby, and Gibby in 2004 analyzed human bone tissue obtained from patients who underwent hip joint replacement surgery where the femoral head was removed. Significantly higher levels of gadolinium was detected in patients who had received gadolinium-based contrast agents. Zia, Davis, Crawford, and Abraham in 2010 performed a retrospective study analyzing brain tumor biopsies following at least one MRI scan enhanced with gadolinium-based contrast agent. These scans found insoluble deposits containing gadolinium within highly vascular areas feeding the central nervous system. A groundbreaking study by Konda et al. In 2014 found gadolinium deposition in the brain. Konda et al. First reported an increase in signal intensity in the dentate nucleus and globulus pallidus on unenhanced T1 weighted images. It's important to note, unenhanced T1 weighted images. This was compared to a group of patients who had undergone at least 6 contrast-enhanced examinations to a group of patients who had undergone only non-contrast examinations. All patients received linear agents because these gadolinium-based contrast agents were the only agents used at that particular institution. As you can see here, we have images of patients who had not received gadolinium-based contrast agents, and there's no increase in signal intensity within the dentate nucleus. But then here on the right, you can see the higher signal intensity on the unenhanced T1 weighted images for those patients who had previously received gadolinium-based contrast agents. And once again, these agents were linear because they were the only ones available. And then over here we have the control patient, where the patient had not yet received gadolinium-based contrast agents, and you cannot see an increase in signal intensity in the globus pallidus. After their first exam, MRI contrast with contrast, you can't really even see an increase in signal intensity on unenhanced T1 weighted images. But then you have patients that have received multiple doses of contrast throughout their lifetime of gadolinium-based contrast agents. And you can see on the T1 unenhanced image that there's an increase in signal intensity in the globus pallidus for those particular patients. Konda et al. Followed up their study with another study in 2016 comparing macrocyclic and linear gadolinium-based contrast agents. In this study, 23 patients received linear agent and 36 received a macrocyclic agent. 9 patients had hyperintensities in the dentate nucleus on unenhanced T1 weighted images, and out of those 9 patients, 7 were given linear agents and 2 were given linear and macrocyclic agents. So let's talk about gadolinium deposition disease, and if there is such a thing as called gadolinium deposition disease. So clinical significance of retained gadolinium in the brain remains unknown, since no adverse health effects have been linked to date. MR professionals then should practice caution about potential overprotective measures against gadolinium-based contrast agents used in clinical practice. Long-term studies are required to conclude whether gadolinium deposition in the brain causes subtle neurological deficits. Murata et al. In 2016 hypothesized that free gadolinium, which has an ion radius close to that of free calcium, could block the activity of some calcium-dependent enzymes and block calcium channels, leading to problems with muscle contraction or nerve conduction. Many of these symptoms are analogous to NSF, but are less severe. Another hypothesis is that since gadolinium deposition primarily occurs in the dentate nucleus and globus pallidus, it is likely that any clinical manifestations would relate to dysfunction of these structures, such as movement disorders or even issues with balance. The last long-term adverse effect of gadolinium-based contrast agents are anthropogenic or anthropogenics. This is the process of gadolinium entering the drinking water system from patients who had received gadolinium-based contrast agents. Since gadolinium is not a common occurring substance in nature, it must have been put there by humanity. The highest levels of gadolinium in drinking water have been detected in cities with large healthcare systems. So these patients are receiving the gadolinium and then excreting it into the toilet, and then it's getting into our water system. The clinical significance is still unknown, and further research still needs to be done. Let's discuss the current recommendations regarding gadolinium-based contrast agents. I will discuss current recommendations by several agencies, groups, and I'll also discuss how each facility should update their consent forms. The European Medicine Agency recommended a European-wide suspension of all commercially available linear gadolinium-based contrast agents, aside from liver agents. The US FDA in 2015 began to evaluate gadolinium deposition. In 2017, they published guidelines stating linear gadolinium-based contrast agents result in more retention than macrocyclic gadolinium-based contrast agents. They recommended healthcare professionals should consider the retention characteristics of each agent when choosing a gadolinium-based contrast agent for patients who might be at a higher risk for gadolinium retention. Those patients who may be at a higher risk include patients who require multiple lifetime doses, pregnant women, children, patients with inflammatory conditions, and patients with renal insufficiency. Gadolinium retention and deposition is particularly concerning in pediatric patients who are undergoing neurodevelopment and active bone formation and remodeling. At present, only 2 macrocyclic agents are licensed by the U.S. FDA for use in patients younger than 2 years of age. The American College of Radiology identified gadolinium-based contrast agents associated with the greatest apparent NSF-associated risk, the Group 1 agents, and recommended that their administration be avoided in patients with an eGFR below 30 or in patients with acute renal dysfunction or on hemodialysis. The Japanese Pharmaceuticals and Medical Device Agency requested an update for all gadolinium-based contrast agents packaging to include precautions about gadolinium retention on all labels. The International Society of Magnetic Resonance in Medicine stated, as per standard practice, MRI techs should document clinical indication for which the gadolinium-based contrast agent is administered, specific contrast agent use, dosage, and other pertinent information in the patient's medical record. It's also important that radiology department administrators need to decide whether to include information on gadolinium deposition in the brain as part of their contrast consent form. Emory updated their contrast consent form to include gadolinium deposition. They included tiny amounts of gadolinium from MRI contrast agents can stay in the brain or other parts of the body for months to years. This can happen even in patients with normal kidney function. No known health problems are currently linked to this, but it is possible that in the future there may be health problems from gadolinium staying in the body that we currently do not know about. Finally, let's talk about some alternative imaging techniques that will reduce or eliminate the need for gadolinium-based contrast agents. The first one is artificial intelligence. With AI, complex machine learning algorithms can extract the contrast signal from low-dose gadolinium-enhanced images to produce synthesized contrast-enhanced MR images. Machine learning has shown great potential in preserving image quality and contrast information on MR exams of the brain where only 10% of the recommended dose is administered. Gong et al. Reported significant increases in image quality and contrast enhancement of the synthesized images compared to low-dose images. As you can see here, the synthesized images compared to the low-dose images. And a slightly but not significant reduction in image quality and contrast enhancement of the synthesized images compared to the true full-dose images. So you can see here's the full dose, and here is the synthesized images where only 10% of the recommended dose was administered. Another alternative imaging technique is time of flight. So in MRI, we are already utilizing time of flight imaging to visualize the vascular structures without contrast enhancement. Time of flight as a sequence is typically a gradient echo pulse sequence. Gradient echo sequences are flow-sensitive pulse sequences because gradient rephasing is not slice selective. The stationary tissues, like brain tissues like gray and white matter, will become more saturated due to the short TRs and repetitive RF pulses. The saturated tissue will have a dark signal, and flowing nuclei that comes into the stack will appear brighter because it will be fresh and less saturated by the repeated RF pulses. We have the option of choosing 2D versus 3D time of flight. 2D is useful when imaging the carotids because we are able to cover a larger area or field of view without vessel saturation. 3D time of flight is more geared towards imaging the circle of Willis. The final alternative imaging technique used to eliminate or reduce the need for gadolinium-based contrast agents is 4D arterial spin labeling. Arterial spin labeling is an MR technique in which arterial blood is magnetically labeled or tagged using saturation pulses instead of gadolinium to measure tissue perfusion at the capillary level. Studies have shown that 4D ASL is outperforming time-of-flight imaging. As you can see here, we are starting to even visualize the vessels that branch out even further into the brain. There will be a continued desire for advanced imaging techniques that reduce or fully eliminate the amount of gadolinium required until the clinical implications of gadolinium deposition are fully understood. So in conclusion, gadolinium-based contrast agents are used every day to help radiologists accurately detect and diagnose a wide range of pathologies that might have gone undetected without contrast enhancement. Gadolinium-based contrast agents on the market vary by stability, structure, osmolality, viscosity, and T1 relaxivity. Current literature suggests that less stable non-ionic linear agents accumulate in tissues at a higher rate than do ionic macrocyclic agents. Deposition still occurs with more stable macrocyclic agents, but at a lower level. The clinical significance of retained gadolinium in the brain remains unknown, and further studies are needed. Long-term studies are required to conclude whether gadolinium deposition in the brain causes subtle neurological deficits. These are my references. Thank you.